I want us to talk about CBC today. I want us to talk about rethinking complete blood counts, okay? So this is a thought-provoking presentation authored by the entire HuQAS team, not just myself, but Gladys Ndegwa Watene, who just presented, okay? And it is something that we'd want to share with you as well. So CBC, according to data, CBC is the most widely ordered lab test. As of now, CBC is the most widely ordered lab test. I think we can concur. Even here, when we sit, probably when you do our metrics, you'll realize that the number of hemograms that you're doing in a day is what is giving you more money in the lab, okay? So yet, even if we are doing so much of this, yet it is also one of the most confusing to interpret. Why? Because as we continue on, our reports are becoming bulkier and bulkier. As of now, we are reporting over 20 parameters in one CBC report. If you have a 5-part, proceed to a 6-part, then the report becomes more. You come from 20, you go to up to even 25 or 27 parameters. So the question that we want to ask ourselves is, are the more parameters we are adding, are they adding value to patient care, or are they overwhelming clinicians? Okay? So there is a recent article that was done by the hematologist, which is the American Society of Hematology, that argues maybe it's time, we need to do something about it. So that's the article I want us to discuss. So in 2024, two gentlemen, Burack and Lichtman, did a journal proposing a new approach to CBC to improve clarity and clinical usefulness. Just a bit of background, these two are hematologists and one of them is a clinician. So what were the key recommendations? They offered 3 recommendations. Number 1, remove low impact indices. What are they classifying as the low impact indices? MCH, MCHC, and relative WBC percentages. Number 2, their proposal was use hemoglobin alone to represent blood oxygen carrying capacity. So meaning we drop total RBC counts, the MCH and the MCHC, but the only indices to remain is MCV and RDW. Tuko pamoja hadi hapo? The third one, they recommend eliminating total WBC count, absolute total WBC count, in the event there is a full differential absolute count. So if a full differential absolute count is present, then they see no need to have the total WBC count. So what is their rationale? According to that article, they would say that HB is the best reflection of oxygen carrying capacity, not RBC. That HB, when combined with MCV and RDW, is the most essential for anemia classification, and that MCH and MCHC are redundant right now, and they add little diagnostic value. That relative WBC percentages are outdated because the absolute counts are more meaningful. Yet, they also say that total WBC is redundant if absolute differential count is available. Keyword is absolute differential counts. So not just reporting the total WBC, but also reporting the absolute count for neutrophils, for lymphocytes, for eosinophils, for basophils. This is what they are proposing. They are proposing a tiered approach towards CBC. How do we go about it? So they have classified it into 3. The first one, they are calling it the CBC core. So this to be done for healthy individuals, majorly for screening, for admission, for outpatient visits. And what would it include? Only 5 parameters, that being hemoglobin, hematocrit, total WBC, platelets, and MCV. Okay? Then have another panel or profile that they are calling the CBC diff. So the CBC diff, its intended use would be patients under treatment, follow-up, so that is for chemo, for transplant, for infection monitoring, and for this, it would be everything on the core values, that's the 5 core values, plus absolute differential counts. Then, they are also recommending that CBC plus which is the last one, or CBC diagnostic, be a profile that is done for full hematology evaluation, especially in cases where you are suspecting the patient has blood disorders. And for this, they recommend everything that is present on the CBC diff, plus RBC indices, which are the RBC count, RDW, reticulocyte count, plus blood smears. So their recommendation is not to remove total RBC for all, but just remove it for the first 2 cases, meaning for screening and for follow-up, but only have it when you're assessing, when you're suspecting a blood disorder. So from this, we did a little digging. So what are people saying worldwide? So there was a study that was done in Cleveland, Ohio in 2002. It sampled 2,000 physicians, and from this, they found out that 90% of these physicians only use HB, HCT, WBC, platelets, and MCV in evaluation of anemia. There was another study done in Pakistan in 2020. It sampled 217 physicians as well, and from there, they found out that clinicians only relied on HB, WBC, and platelets. So meaning, most clinicians saw very limited value in the rest of the CBC parameters. So what does this mean? It means that even globally, a lot of clinicians are only seeing, will I say, a small subset or are only using a small subset of the CBC reports that you are giving them. So locally, we needed data. So as HuQAS, we did a survey. So the aim of our survey was to understand local views on the proposed changes on clinical practice and patient care, and we received a total of 46 respondents from this survey. Majority of the survey respondents, 65.2%, were lab techs, and we had clinicians and we had hematologists, as you can see the 8.7% that is present there, who also gave us feedback. So that is what I want us to analyze today. So amongst our survey questions, what did we ask? We asked, do you believe MCH and MCHC still add diagnostic value or interpretive value in your setting? That means in your facility. Would reporting only HB without RBC, MCH, and MCHC risk missing early IDA or thalassemia traits? And should relative WBC percentage be removed from reports if absolute counts are available? And would removing total WBC be confusing to the clinicians in the current practice? And do you think most clinicians in your setting understand or use WBC counts confidently? So these are the responses that we got. I'll tackle them in 2 ways, from the clinicians and the hematologist, and from the lab personnel. So, from the clinicians, on removal of MCH and MCHC from the report, 60% of them agreed and said that they are rarely useful and they should be dropped. 40% said they are still helpful for analyzer flags and smear correlation. On reporting HB only without RBC, MCH and MCHC, all of them expressed caution. The key words they would use is that, number 1, it would risk missing IDA or thalassemia, that RBC values are still important in some context, that it also depends on clinical information given the skill of the pathologist and if RDW and MCV are available. So we also asked on the relative WBC percentages, should they be removed? 75% of them agreed and said that they should be removed because it's confusing, especially for junior clinicians. 25% did not agree with it. They said it should remain because it offers a quick review, especially in infection. As of total WBC, so 100% of them agreed that total WBC count should be present in the reports, and they said that clinicians rely on it as a reference point, even if it's redundant. So we asked also, do the clinicians in their setting have confidence in using WBC absolute counts? This was a bit conflicting. The clinicians said they are well adapted, but the hematologists said they don't think the clinicians are well adapted. So the hematologist, or rather the pathologist, thought that many of them still rely on the percentages and the WBC counts. So this was interesting. So what would be the impact of simplification? Many of them said that it could really improve clarity if education, guidelines, and more studies were done locally. So what about the lab professionals? So for the lab professionals, we asked, should MCH and MCHC be removed? 72% said that it should not be removed because it's widely valued for anemia classification, hypochromia, and analyzer flags. So 72% of them said it should remain. 28% said it's really useful and should be dropped if MCV and RDW are available. For HB reporting only, without RBC, MCH, and MCHC, these 95% strongly opposed, okay? So key comments that we got on this were that in cases of low HB, low MCV, one wants to correlate MCH in cases of IDA, thalassemia traits, or possible spherocytosis. That reporting HB only makes it hard to properly classify anemia in cases of hypochromic and pneumochromic, or establish the underlying cause. Someone also said that it helps in early suggestion of spherocytic anemia before requesting retic count, which requires separate reagents and adds cost to the patient. So on relative WBC percentages, this, I'll call it more of a tie, but 55% of them agreed and said that it was redundant and confusing and should be removed. 45% said that it was useful for infection overview. For total WBC count, there was a strong consensus. 90% of them said we keep it because it's heavily relied on by clinicians. On clinician confidence in the absolute counts, so it was also a tie. 50% said that the clinicians in their settings are well adapted and they trust the absolute counts and they're able to use them. And 50% said that they still heavily rely on percentages and total WBC count. So they do not use the absolute values very well. So what would be the impact of simplification? So many of them said that if we do this, there will be risk of errors unless it's paired with education and pilots. And even some went ahead to suggest that even platelet indices as well should be removed. That came out strong as well. So just to highlight some of the responded voices that we got or views, the first one was simplification could be a good move. We only need to create awareness and educate clinicians. Someone else said that I have observed clinicians misusing CBC reports by considering WBC percentages whenever the absolutes are within normal and the percentages are out of range. Some said that MCH and WBC percentages should be removed completely. They mislead clinicians. Some said that removing parameters risk diagnostic error, better to offer learning platforms for clinicians first. So some said CBC should be more elaborative and direct. So for them, they would encourage adding more parameters rather than minimizing. Yes, very interesting views. There are people who said more training to the clinical team is necessary to upscale their skill and improve patient management. There are some that said if simplified, keep total WBC count and absolute count, differential counts, RBC indices, but remove all platelet indices. Yeah. So there's someone who said oversimplification can lead to misinterpretation, especially in facilities relying on full parameters. Another said we should not hurry to change things because community input is needed. There's another who said clinicians may misinterpret CBC without orientation. Simplification is good, but omitted parameters are still useful for pathologists and hematologists. So those are some of the exact voices. These are exact quoted voices of people who responded to the survey. So what does this mean for us? So what are the key insights from this local survey? The first thing is that for sure, CBC simplification is needed. Simplification is really needed, but there has to be a balance. There are people who really are emphasized on caution. So the key thing here is if any simplification is made, there must be a balance between the clarity and patient safety. So from the local consensus, most people, in fact, this is from the hematologist and the lab personnel, HB only without RBC, MCH, and MCHC, all of them agreed that it risks missing thalassemia, spherocytosis, or early anemia. And that total WBC, for total WBC counts, most clinicians still depend on them as a reference point. And for relative WBC percentages, this remains controversial from all. As you've seen, there are some who said that they are often misused, yet there are some who rely on them for a quick overview, okay? So from this, globally, based on the studies that we've highlighted, we've seen that MCH and MCHC are seen as low value indices, but locally, most, especially the lab professionals, still want them. It's still highly valued locally because of classification and analyzer flags, but less so by the physicians and the hematologist. So the conclusion, my conclusion is that, of course, this simplification right now is a hot global debate, and would love to hear your input on it. And what is the path forward? So what we need to do now, we need more local evidence. As you've seen from our survey, we only got 46 respondents. We were really targeting physicians, so it would be nice if you can get their view as well, because they are the consumers of the report. So we need more pilots and outcome studies. We need to engage clinicians in interpretation workshops, and also we probably need to have a policy dialogue, because who are our regulators? The MOH, the KMLTB, the KMPDC. So what can we do about it? Thank you very much. Asanteni.